Awesome. Hello, 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 everyone. This room is filling up quickly. 107 people are already here. We're so glad and so excited to see you all. As we welcome people in the space, I'd love to know where you're zooming in from. Let us know in the chat, say hello, and where you're zooming in and joining us from. I am usually in Atlanta, Georgia, but today I am in South Carolina visiting my mom, my dad. They are keeping my niece and nephew for the summer, and my niece and nephews for the summer, and I've come to help. I'm flying in to be the fun auntie, and then I'm flying right back out. So it's super exciting to see everyone. Harrisburg, Pennsylvania, Florida. Aloha, Linda. Aloha, Tiffany. Oh, I would love to visit Hawaii one day. So many people from so many places, New York. Okay, Linda, I'm serious. I'm coming. I'm coming over. So excited. Hey, David. Hey, Katie. Katie's coming too. Come on, Katie. Let's go. Dawn in Tennessee. Hey there, Dawn. So exciting to see so many of you all. We have a lot of information to cover in an hour. So we're going to start on time and get us going. Before we get started, I do want to let you all know this disclaimer. We are recording today's session. You all will receive the recording after today. We'll make sure you have it available. We'll have it on our website. We'll have it on our YouTube, all the different places. And please know that our speakers today, they are incredible. They are wonderful. And their views that they're sharing are views of their own. They don't necessarily represent SAMHSA or INTAC. So want to let you all know that. And I'll drop the rest of the disclaimer in the chat in just a second, but just wanted to give you all that information. Should there be any type of glitches, but we are knocking on all wood everywhere around us that there won't be. But if there are any glitches, we will close this session down and let you know how you can rejoin or have access to the information. I want to give a big shout out to our partners that help us make sure that these sessions are available to you all. So we have partners from all over the country, Change Matrix, Georgetown University, AAP, and lots of others. So big thank you to our partners. And we provide all of our services at no cost. And we hope that this won't be the last time that you join us. Please make sure that you are on our listserv so that you receive announcements and information about all of our upcoming events. We also provide one-on-one technical assistance. So if you're experiencing any type of challenges or issues with things that are happening in your part of the world and you want a little help, you need someone to talk to, you need some new resources, feel free to reach out to us. We're more than happy to be there and support you in any way that we can. So with all of that being said, I want to pass the mic over to two people that I consider my friends and colleagues. We used to work together in injury prevention, and I just adore them. I'm going to give them the opportunity and the space to introduce themselves, but passing the mic over to Grace and DeAndre. They have a lot to share with us about how and what it looks like to prevent ACEs from a state government lens. I know we've talked about ACEs in previous sessions, what they are, some statistics. Now we're talking about action. What do we do about preventing ACEs? So super excited to hear what Grace and DeAndre have to share with us today. And I'm going to pass the mic over to them.
Thanks, Ashley. Well, good afternoon, good morning to some of you. I've seen all the way back to Hawaii. So good afternoon to everyone. I want to start off by thanking you so much for allowing us time, space, and opportunity to come and speak with you today about a few things that we are both so passionate about. We want to talk to you about public health state actions to prevent ACEs and uplift PCE. So that's adverse childhood experiences and uplifting positive childhood experiences. My name is DeAndre Kane. I am the Core SIP, Core State Injury Prevention Program, Program Manager and Principal Investigator. and I am our Comprehensive Suicide Prevention Co-Principal Investigator with the Georgia Department of Public Health Injury Prevention Program. And I'm here with.
Hi, everyone. My name is Grace Morrow. I am the Preventing Adverse Childhood Experiences Data to Action Principal Investigator and Program Manager. And I am lucky enough to be able to work with DeAndre every day. And we are so excited to see all of you here. And we really do thank you for your attention and your time. So I'm going to just really briefly describe what our presentation is going to be like today. So DeAndre and I are going to be explaining to you essentially three things. The first is how we run things. So we work at the Georgia Department of Public Health, and within that, we're in the Injury Prevention Program, also called IPP. So we're going to talk to you about how the Injury Prevention Program is structured and funded. We're going to show you what our 9 different programs are, and then we're going to talk about what our 2 overarching governing philosophies are for the Injury Prevention Program. So we have these 2 larger perspectives or ideas that we utilize in terms of determining what grants we're going to apply for, what kind of projects we're going to do, and then we're going to talk with you more about our specific approach to ACEs and PCEs and how that's incorporated with our overarching philosophies for the injury prevention program.
So the Injury Prevention Program, we are 100% grant funded. This means that in turn, we have certain requirements that are handed down by our funder and things that we have to meet per different deadlines and deliverables. But with that, as a group and collective, we've decided to take it further. And so with that, we want to make sure that we have intentionality of program integration and detail across programs and collaboration. So with that, we want to make sure that we have inclusion and involvement of the different organizations that we work with, the stakeholders, the populations of interest, and make sure that everyone that we're working with has input and say. There's also, we want to be intentional with our partnerships. We want to make sure we're working with people who have similar goals, values, missions, and objectives that we have. So that way, once we're in the space that we're working from, we want to make sure everyone's included and have the opportunity to give input. Along those same lines, we want to make sure that we have leverage and alignment of programs and partnerships. So we want to make sure that we're thoughtful and considerate of who would work best with whom. We want to bring everyone to the table, have collaborations that make sense, are authentic, and just work together seamlessly as we're working toward those goals. All right, so one of the, as you see here on the screen for us, we have injury prevention program mapping. So we have 9 programs in the injury prevention program, and one of our overarching themes is injury across the lifespan. So with having that said, so we have programs ranging from infancy, our Safe to Sleep program, to older adults, which is our 55 plus driver, and our BOLD preventing dementia program. And we also, in between there, we have programs that touch a little bit of everything. And so we have our core SIP, the State Injury Prevention Program, which I'm the program manager of. We have our Comprehensive Suicide Prevention Grant, and we have our CODES work. And CODE stands for Crash Outcome Data Evaluation System. They handle most of our data for our motor vehicle portion and area of interest for there. So out of those 6 non-programs, 6 of those have ACEs components. And so we have our core SIP, we have the community cafes in the Albany Public Health District. So with this, we're equipping community members, parents, students, and anyone who has a positive impact onto a child's life with the skills, tools, and knowledge to be able to address certain issues and give those tools to help equip the student to be of optimal health and have a great mind state. Also, in our Columbus Public Health District, we do child passenger safety technician scholarships and sponsorships. So what we do is we are paid for someone to get trained as a technician, and we want to make sure that we're impactful in that way in the Columbus Public Health District. For CSP, Comprehensive Suicide Prevention, our focus is Black youth ages 10 to 24 in Clayton County. For Prevail, Prevail stands for Preventing Violence Affecting Young Lives. There are multiple forms of violence impacting adolescents and young adults in communities with high rates of violence. And with that, they have they're making a big impact in the Athens-Clarke County region. For PACE D2A, they're utilizing data to inform tracking, prevention, and community efforts, measuring successes. With the Child Occupant Safety Project, COSP, they have a car seat program where they have seat check events, where they switch seats or they inspect seats, as well as we know seats expire, or so we're making sure that people have the tools and knowledge to understand that they're using things correctly, or if they don't have a seat that's not up to standards, they have opportunity to switch those out. And also they hold and train classes for child passenger safety technicians as well. In our Safety Infant Sleep program, it's public health interventions intended to protect infants from sudden unexpected infant death syndrome. So out of the programs I spoke to you about in the previous slide, they have 3 different funders. I like to call them 3 buckets of money. And so our first bucket we have is a CDC funding. We have 4 programs that are funded under the CDC. We have PACE D2A, Core SIP, our Comprehensive Suicide Prevention Grant, and Prevail. The next funder is Governor's Office of Highway Safety for Georgia. And they have the program they have is Child Occupant Safety Project, Codes, and the 55 Plus Driver Safety Program. And MCH Block Grant has the Safe Infant Sleep and Bullying and Youth Suicide Prevention. Now, while everything is in separate buckets, as you see here, work is done separately, but also everything is done with collaboration, intentionality, and thoughtfulness, how we can integrate and work together.
So DeAndre just talked with you a little bit about what the injury prevention program looks like, how we get our money, and also what types of programs we have. So I'm going to talk with you about our 2 overarching philosophies that govern our 9 programs. So the first is utilizing the shared risk and protective factor approach. If you're not familiar with this, it is pretty much essentially what it sounds like. This is the concept that various different health outcomes, such as experiencing teen dating violence or experiencing suicidal ideation, that those can have some factors, some shared risk factors, or some shared protective factors. And so the idea is that when you are working on a specific risk factor or a specific protective factor, your focus might be, oh, I want to prevent teen substance abuse, or I want to prevent teen dating violence. But if you're working on a shared risk or a shared protective factor, you're also potentially working on suicide prevention, on mental health issues, on sexual violence prevention. And really this perspective, the reason why it's helpful is because it allows you to maximize your resources and really increase your impact across projects and across programs. So one of the other great things about the shared risk and protective factor approach is that it's applicable to all levels of the social ecological model. So you're going to have various different risk factors or protective factors at all of these different levels, and your programs or policies or data can look at all of these different things. So it's really diverse. You can really apply it to any type of program or any type of project that you're trying to do. This is an example of a shared risk factor. So the risk factor here is substance abuse and everything around it. These are all health outcomes that we know research has proven are directly related to substance abuse. So you might be really interested in preventing motor vehicle crashes. That's a huge thing in injury prevention. And one of the ways that you might want to do that is by limiting drunk driving or opioid use. And so you have some campaigns or projects that are geared towards that. But at the same time that you're doing that, you're also going to be impacting all of these other health outcomes, these injury-related health outcomes at the same time. So really, you're doing a lot more work than just preventing motor vehicle crashes. And that's the same thing for the protective factors. If you're going to focus on a protective factor, that is also going to impact any of the other health outcomes that are related to that. And then this matrix is, this is from the CDC. So the shared risk and protective factor approach, that is something that we learned from the CDC. They have some great resources on it. We've got a link to that later on in the presentation. And this matrix here is particularly focusing on shared risk and protective factors around traumatic brain injury. So you can see that we've got various different levels from the social ecological model off to one side, then specific risk factors, and then various different health outcomes. So you can see here, for example, that having a history of violent victimization, that's related to traumatic brain injury, motor vehicle crashes, or not motor vehicle crashes, but child abuse and neglect, intimate partner violence, and sexual violence. So really, kind of the idea behind this approach is to not silo our work, is to acknowledge that when you're working on one thing, you're actually working on others, and you can utilize this to maximize your impact. So and the way that we approach this within the injury prevention program is we build our 9 different programs off of one another, and we make sure to incorporate them in one another's grants. So even though you might think, well, child occupant safety, that might not be something I traditionally associate with ACEs, the way that we see that is we're helping to solve some social determinants of health problems for folks that don't have access to knowledge around how to safely secure a child in a car seat, or who might not have access to a car seat. And that's also buying us face time with families and caregivers where we can potentially implement some other programs or incentives with them. Now, the second sort of overarching philosophy that we have is really looking at injury across the lifespan and ensuring that we are addressing every stage of life throughout our 9 programs. And for the sake of this, we're considering, in the womb, and then, all the way to being an older adult when we're nearing the end of our life. Now, one of the things that we think is particularly important is we tend to view, in public health, we tend to view the lifespan as linear and always going in one direction. And that is literally quite true. And one of the things that we often do is divide populations based off of their age. And we, specify different programs or different types of interventions based off of different ages. And that's valuable, and that should continue to happen. But one of the things that we are really interested in doing is acknowledging that even though you might specialize in working with one, age group, what's happening in that age group is impacting all of the other age groups that we utilize in public health. So life is linear, but the way that our lives interact with one another is not. So an example of this could be that you have a young adult and a great grandparent, for example, and maybe that young adult is responsible for bringing that great grandparent to their doctor's appointments. But if that young adult happens to have a substance abuse problem, and maybe they get a DUI or they get involved in a crash and their license is taken away, then that's an issue in itself, but it's a greater issue because what's going to happen with that great grandparent who still needs to go to the doctor? How are those services going to be fulfilled? And it's the same. All of these different relationships can be interconnected with one another. So no matter how old you are, what age group you're in, your health is relevant to everyone else's around you. This is, again, another reason to use that shared risk and protective factor approach, and is also why we think it's super important to be addressing injury literally throughout the entire lifespan. That's why we've got from pre-birth all the way to the end in our programs. And now we're gonna kind of narrow down a little bit more, and we're gonna talk specifically about the data to action approach, which is what we use primarily in our ACEs and PCE prevention work.
So when we talk about data to action, I don't know about you all, but I'm a process person. So I need to know that, I need to know the background, why it happened and everything before I can catch that full concept. So with this, the process to guide evaluators and practitioners using a rapid feedback cycle to generate actionable data for implementation and multi-component programs. So with that, the efforts began to prevent domestic violence. The framework was designed through the Delta Prep CDC as a 3-year project to understand and build capacity for the domestic violence coalitions to prevent intimate partner violence. So with that, there are a few purposes for the program. So program development, you have program refinement, program improvement, and opportunities to identify barriers to implementation and program creation. So there are 5 steps in the data to action cycle. So the first step is the intent of data collection. So with this, this is where you're formulating, you want to ask the question, you're determining viability, and you want to establish a baseline of understanding for what you want to ask, what you want to understand and figure out. Step 2 is collecting good enough data. Now we have good enough in parentheses, but what this means is sometimes the data isn't always there. So you have to take opportunities to understand, know what you're looking for from step 1, and then you have to go back and either pivot, or you have to find ways to collect data yourself, or you might even have to go back to step 1, change your question so you can have that answer be provided by data that is supported with that question. So you have step 3, all right, produce a memo. It says produce a memo, but this is basically the portion where you create deliverables or tangibles based on the data that you have, and step 2 on collecting the good enough data. So with this, a few examples of the tangibles can be action plans, progress reports, evaluation plans, or can need to be reports that you deliver or share with funders or different other stakeholders that may have interest in the work that you're doing. Step 4 is reflective debrief. So this is where you take your opportunity to take a look at what was learned, lessons learned, taking the opportunity for quality improvement, efficacy, and efficiency. So this is where you're taking a look at what you're doing, going back through and see where you can change in the moment and make it more effective. And if you need to go back into any step on the step of the cycle, and then you can do this as well here. For step 5, this is where you make all your decisions. So this is where you're going to take opportunity to look and see whether you need to make any changes in the scope depth. If you need to scale up and see how you can have a wider range of what you're looking at, scale down, see what you're looking for, make it a little more granular. Or if you have any depth you need to look for, or if you need to bring on partners that we can increase your reach or range, this is an opportunity to do that too. But this is all opportunity to build in for year 2 or the next iteration of the intervention that you're currently working on. And also with this step, you're working on the D2A step, looking at diversity, equity, and inclusion. And so for this, you can't answer the questions if you don't have the answers. And so this is where a large part of that is also placed. So next, what we're talking about is the 2 types of data to action. So we have our general data from recurring sources such as yearly, state, or national surveys. So an example for this that CoreCiv uses is the kids count data. So with this data, it's an annual survey, and we get the data on an annual basis. And usually it is pretty regular, depending on what's going on in the world. Over the last few years, we've all kind of experienced a collective ACE, but but we're moving through that. But with the general data, it allows us to understand geographically, programmatically, and strategically. So if we're looking for something that's happening in a specific region, or looking for something, a program we want to gear or direct toward a certain region or a population of interest, or even if there's a specific focus that we want to make sure that a specific focus that we want to go ahead and bring to light, like diversity, equity, inclusion, or for certain areas of populations that are underrepresented or underserved, this will be the opportunity to pull that data and utilize there. So with evaluation data, this is the overall program evaluation. It could be various techniques. It can be qualitative, quantitative, and you have opportunities to use this in the continuous quality improvement method, which means you're making changes as we go or as the process is moving along, or in the traditional form to have the evaluation at the end. So with this, you're able to develop short and long-term recommendations to improve the project efficacy. And also the whole process in general for evaluation data, it provides insight and so you can have the maximum impact for the work that you're doing in order for the program that you're implementing. So here we have the data to action benefits. We've identified four overarching benefits here, and then we'll talk about the ones that are attached to them individually. So we have the deeper insights, fast and secure connections, sharing more, and flexibility for the future. So for deeper insights, we have health equity. And so in order to make the change, you have to ask the question. You can't address the question without having the data. So all this goes back to that D2A five-step cycle that is going to be utilized through every aspect that you have. So with data linkage, this is where you have an opportunity to take two seemingly unrelated things like, well, not unrelated, but that you wouldn't exactly have to look at in a particular way. But you have the crash records data, you have hospital discharge data. So if you're looking at for child occupant safety, so you're looking at if a child was properly restrained and you're combining that with the intersectionality of hospital data, and you'll have an understanding or overarching look at how that one effort impacted the other, and you'll be able to look at the intersectionality and the impact that that decision had in the training. For fast and secure connections, we have interoperability. So this is credibility is established. You have existing relationships. You're constantly working together, and that underlying trust is there. And so that feeds directly into the security and structures in place. So of course, with data, everything we do is sensitive data unless it's de-identified, but even then it has some level of sensitivity. So we want to make sure that we're being good stewards of the data, and so protecting it and using it in ways that make sense. But since we have that relationship already established, the protocols are in place and there's less risk of improper use of the data. So of course we are sharing more. So as everyone knows, sometimes data is not always easy to get. So we have the open data. And so the data is available and it has access be able to share. So with that, usually you have process and approvals to be able to get to the data. And so with this, you already have that in place. And then so if you have someone who needs the data, you can share it easily and without complication. Because sometimes getting that data itself is a hurdle that you have to overcome. And so we also have common operating procedures. So with that, you have a standard operating procedure that you have, and you're kind of avoiding individual requests for the data. So you have this available, you're working with it, it's already in a place where it's shareable. And so you have it reliable and there to be able to share it, and you can just go ahead and hand that out as needed by stakeholders, funders, whoever has interest in the data. And last, we have our flexibility. And so with this, we have scalable emergency response. So this means you can look at the data on any level, whether it be local, county, state, or even public health district. And so you'll be able to take a look at that from different levels and understand and take a look at what you're looking for or any areas that need specific attention. And as we do in public health, we want to look toward the future. And so we have opportunities to forecast, look at the analytics, so we can take a look at what's coming around the bend as we prepare for things that we can't be known.
So now I'm going to talk to you about some of the facilitators and barriers for utilizing the data to action approach. And these all come from what we have noticed while implementing the PACE D2A project and some of our other programs. So some of your greatest facilitators are going to be having multiple sources of data. This goes back to that second step in the data to action cycle of collecting good enough data. The question that you're initially trying to answer, or the health issue that you're initially trying to tackle, you might not be able to have access to the data that's actually going to answer that question for you. And so being able to have more than one data source, you might be able to get snippets or pieces of the picture from one data source and then get another from a different one. So the more sources of data that you have available to you, the easier it's going to be to answer your question and to affect change. The second thing is having strong and diverse partnerships. I'm sure that you all have heard this when you're talking about essentially any kind of strategy that you're trying to use, but the more folks who you have who have come to the table, the more people whose voices can be heard and the different strengths and resources that other organizations have, the stronger your overall program is going to be. And the way that we utilize the data to action approach, we're trying to present data to folks so that they can then use that data to implement programs and practices and strategies and policies through whatever line of work that they have to do that's related to ACEs or PCEs. So the more people that we have who we're working with, who we can share our data with, the more action we're going to have. Now, when we talk about community participation, the idea here is that for the injury prevention program, we think it's really important to work with people and to not work for them. We don't want to go into communities or into specific demographic groups and say, hey, our data is telling us that these are what your problems are, and so we think you need to do X, Y, or Z. We want to be able to say, this is the information we have about your data. What from this seems interesting to you? What is it that's going to be helpful to you, that's going to uplift some of the programs that you're already doing in your community? And for that, we're going to get an increased level of participation, especially as a state agency. There is oftentimes an understandable hesitation from smaller or local organizations to work with us, because the fear is, well, they're just going to tell us what to do. We don't want to do that. We want to provide them with resources and with data. So it's really important to have that strong community participation so that their voices are being heard and we can make sure that we're providing them with the tools that they need. It's also helpful when you're talking about the use of the shared risk and protective factor approach, which is also a facilitator. So again, even though we might see in a specific county that they have a real issue with opioid misuse, and that's something that we as the state agency are really invested in focusing on, but folks in the community might say, yeah, we have that issue, but what we're most concerned with right now is teen mental health. Well, you know what? Those things share risk factors and protective factors. So we can say, okay, that's totally fine. We're going to focus on those shared risk and protective factors for opioid use and teen mental health. And we're going to be, getting two birds with one stone. And then the other thing that I've already kind of briefly mentioned is that uplifting of existing efforts. When you're talking about public health, one of the biggest complaints that I hear our colleagues talk about from across the country is that the work is so siloed. Folks who are working in chronic disease aren't doing a lot of work in injury or violence prevention, or even within injury or violence prevention, motor vehicle crashes, well, that doesn't have anything to do with safe infant sleep. And that is that's not necessarily true if you're utilizing that shared risk and protective factor approach. And what you really want to do is unsilo the work. You want to see what's already happening, and you want to be able to not start from scratch, but to build upon what's already existing and accepted within a community. So that's why we say you want to uplift those existing efforts. And that's really easy to do if you're using that shared risk and protective factor approach. And then additionally, having trust between the people who own the data and the people who are going to be using the data is crucial. We deal with a lot of really sensitive data, and protecting people's health information is really important. And it's also really important to be respectful with how we use that data. A lot of times data can be used inappropriately, and it can cause stigmatization of specific communities or specific geographical locations. And so it's really important that we understand how we're going to use that data, and that we have some common agreements or common perspectives with the data owners so that they can trust us with that data that itself is not only sensitive, but also that if it's misused could cause a lot of harm. Now, switching over to barriers, these are all mostly just related to getting good enough data, essentially. So the first one, inability to change data collection. So for my project PACE-D2A, we use 13 different data sources. And as part of the Department of Public Health, we own 3 or 4 of them. So for that data, we don't have any problem getting access to it. But the majority of our data, we don't own and we don't produce. So we have literally no say on how those are being run, if those are going to be changed. For example, one of our most important data sources, the Georgia Student Health Survey, that got shortened dramatically at the beginning of COVID. And so we actually had to totally change how we analyze that data based off of that difference. Another thing that's really important that we found in the PACE-D2A project is being ineffective at communicating data and analysis findings. So there is this sort of divide, I feel like, and not an intentional one, but there's a divide between folks who, have a really strong background in statistics or epidemiology, or who are, biostatisticians, and then program implementers. And while I run a statewide data-related grant, I am not a statistician and I am not an epidemiologist. I am a program person. So I don't have that strong background in data. And so it's really, really, really important that we do everything that we can to make sure that our data is not only accessible in that people can find it, but then they know how to use it, that they have the tools and the resources to be able to effectively use it. And it's no fault of of project implementers or program managers or social workers or whoever that they might have difficulty with understanding data. That's not a failing on their part. What needs to change is the folks that are sharing that data or presenting that data need to do so in an accessible way. Now, when we're talking about access to timely data, again, surveys, they each have their own schedule for how they run. So you might not be able to have access to data to answer a question that you need within a specific time frame. So again, that's where having multiple sources of data is really important. Maintaining sustainable partnerships. Again, one of the strongest facilitators of this approach is multiple different kinds of partnerships with lots of different types of partners. And if your organization has difficulty with capacity in maintaining partnerships, that can definitely be a barrier. And then the last thing is, again, getting towards that collecting good enough data, which is that the data that you do have access to doesn't allow for an in-depth analysis. So what I mean by this is that the data might be useful on one level, but not on the level that you actually need. So an example of this is we have an absolutely wonderful, amazing survey in Georgia called the Youth Behavioral Risk Factor Survey, the YRBS. A lot of other states have it, so it's something that you might be familiar with. Our YRBS asks so many incredible questions about ACEs and PCEs. Truly, it's like a dream, these questions that are being asked. But because of the way that the data is collected, that we can only show that data or talk about that data on a state level for Georgia. We can't actually look at what the YRBS is saying about a specific county or a specific city, which for a lot of the work that we're doing is what people are interested in. So that's where, again, having that variety of sources of data, having access to that data through strong partnerships, that's where that's really important, because you're going to be able to find proxy data or substitute data to help you answer those questions. So now I'm going to talk with you a little bit about my project so you can see how we actually utilize the PACE-D2A approach. And I just want to say that Ashley, in the beginning of this grant, also worked on the PACE-D2A grant as well. So this is also partially her baby too. So essentially what we do for PACE-D2A is we've created sort of a one-stop shop for ACEs and PCE data for the whole state of Georgia. And we've done that by utilizing 12 different data sources. I've got an example of some of those up on the screen. And we use this data to create a variety of different data products that are available on our PACE-D2A website. There's a link to that later on in the presentation. The crown jewel of our data products is a mapping tool where we have probably I think more than 50 or 60 different data points that you can map out across the state of Georgia. And we have that at a geographical range from our Division of Family and Services region all the way down to the census tract range. We've got data at the school district level. It's really wonderful and amazing. And the whole concept of this is that we're making this data that a lot of local organizations do not have access to or don't have the ability to do their own analysis on. We're making it available for anyone who does this work so that they have more resources. And we also offer assistance with managing different data requests or with helping folks to even figure out what type of data it is that they need or that they're looking for. So we get data requests from universities, from other state agencies. We've had data requests from the CDC. We get data requests from a lot of local organizations too. And they could be looking to do anything from trying to decide where geographically to focus on a project, or they could just be trying to make a fact sheet that they want to share with policymakers. And the way that we decide, and again, this is what I would call general data, all of this ACEs data that we have, but the way that we decide how that data is going to get used and which of that data that we're going to focus on presenting is by using our evaluation data. So that second component of data to action. So we do quarterly evaluation reports for PACE D2A, and we utilize those quarterly evaluation reports to see what types of data are people asking for? What is the data that we are missing that we know people want that we're going to try to find? Or are we focusing too much on this one data source when no one is actually really using it? So by doing this, we're able to really quickly respond to the needs of our community and our stakeholders. And that's that data to action component of it. So an example of this is we have thought about uploading some data related to traumatic brain injury with ACEs, which if you're not familiar, TBIs are actually, there's a really big connection between them and ACEs. It's really fascinating. But people haven't been asking us for that data. What people have been asking us for data on is mental health. That's what we've been getting the most requests on. So for right now, that's where we're going to focus our data efforts on, is providing data on related to mental health issues. I'm going to pass it over to DeAndre. So he's going to talk with you a little bit about our comprehensive suicide prevention grant.
So with comprehensive suicide prevention, we have the same framework that is PACE D2A. So we have the data action framework built into CSP grant itself. So we're currently in year one of the grant, and we are recently fully staffed. So we are super excited, and we are ready to move full steam ahead. So with this, we are the exact example of with that good enough data where if you don't have it, you have to make your own. And so with this, the limitations, we have our disproportionately affected population is first responders and military veterans across the state of Georgia. So there's limited data available for that. So we have to take workarounds, piece together efforts from different sources, Georgia Department of Veteran Services, the VA, and different organizations to pull it together and so we can get all the information that we need to see what we need to see. So with this, we had an idea to come up with a framework that's similar to an existing platform called a FASTER platform. That's firearm surveillance in emergency rooms. So with this, they look at syndromic surveillance to look at firearm injuries, and we plan to do the same thing, but with suicide attempts and completions. So like as Grace mentioned, what we're going to do is we want to utilize the syndromic surveillance, reduce reporting times. Sometimes there can be a lag in time between 1 and 3 years. It all depends on the source that you're looking from. So with this, we want to make sure that we're incorporating information to feed a suicide data dashboard. What we're looking to do here is to make sure that it's accessible and digestible. As Grace mentioned, I too am not a statistician in no way, shape, form, or fashion, but what we're looking to do is to provide the information to be shareable and usable. From with this data, a dashboard we want to do is provide training, and that way we can have others be trained on how to use the dashboard, the benefits, or even the functionality of that as well. Also, the initial feedback that we get from the evaluation is definitely going to be used to impact the availability, the access to the public, make any changes that we need to make on the back end, on our end, to make sure it is understandable, usable, and user friendly. And also with this, the evaluation that we get on itself is definitely going to inform the next steps that we have, directionality of program, or make any changes that we need to make it optimal for the work that we're trying to accomplish.
Okay. So I'm going to bring us all home because we've talked about kind of a lot of different things today. We explained how the injury prevention program is structured, what our programs are, where we get our funding from. We talked about the two overarching philosophies that we use in the injury prevention program to guide all of our grants and our programs. And then we also talked with you about specifically what we're doing to prevent ACEs and uplift PCEs throughout the state. And so to kind of bring this all together, especially as a state agency, sort of the way that we came up with all of this was our director thought, well, what is our role as a state agency? What is the purpose of a state agency in the place of this work? And what we decided our role is that's to provide data, develop partnerships, and facilitate collaborations. So we know that these are the three things that we're trying to do, and we're trying to do that with a data-driven approach. So then we thought, okay, well, what are the best ways that we can do that? That's by using that shared risk and protective factor approach so that we can coordinate across programs and collaborate across programs within the injury prevention program, but also with all of our external partners and also our other partners within DPH itself. And then again, using that, looking at injury across the lifespan, making sure that we are addressing high common injury and violence prevention concerns from in utero all the way to the end of life, and acknowledging that our different phases of life have the health that we experience at a different phase of life is going to have a greater impact than just on the individual, but it's also going to have a large impact on their community, which is again furthering the case for utilizing that shared risk and protective factor approach. And all of this comes together to allow us to really easily and seamlessly we interweave our projects together and support one another. So my grant, PACE D2A, we utilize PACE D2A data to help get us the Comprehensive Suicide Prevention Grant, also to help get us the Prevail grant and the current iteration of our CORSIP grant. I also just reapplied for PACE D2A funding, and you bet I used our information and our resources from the CORSIP grant, the Prevail grant, and the Comprehensive Suicide Prevention grant when talking about why we deserve to be refunded for this program. So being able to utilize these approaches, it really allows us to maximize our efforts because we don't have a lot of funding. We don't have a lot of resources, even though we're a state agency. And so we're trying to do what it is that we do best so that we can help our populations and the people of Georgia live healthy and happy lives. Now, this is a resource list that you can all check out. We've got the PACE D2A ACEs website on there if you want to check out our mapping tool. We've got some information on the Comprehensive Suicide Prevention Grant. We have our website. We have the Connecting the Dots link. That's going to tell you more about utilizing that shared risk and protective factor approach. And then down at the bottom, that's a link to the original journal article where the data to action approach was first originated. So you can take a look at that. And one of my favorite things is that both the shared risk and protective factor approach and the data to action approach, those both came out of injury and violence prevention programs. So I think that that's really cool. Now, this is our contact information. If you have questions, if you want to learn more about our specific programs, if you want to collaborate with us, if you just want to say, hey, I didn't understand anything that you said, so I want to have a meeting with you to talk with you more about it, please feel free to send us an email. We would love to talk with you and learn more about the work that you're doing. Thank you, and we're happy to take any questions.
Okay, and Grace, if we could see everyone's beautiful faces and awesome, cool. So there is a question here from Julia, and Julia, I welcome you to ask any follow-up questions. Julia says here, we have a rather high number of military members and their families in our community. We are working with some military folks out here who work in prevention, and they are struggling as they are limited by military data only, which isn't capturing any incidents that occur of base or at the base, or things that aren't being reported to an individual's command staff. We at the state are trying to supply them with some better and more relevant data. There are some definite impacts, protective factors, risks of belonging to a military family. So the question is, are you aware of any community, local, state-based surveys, not within the military, that ask or identify respondents as either as being either a military member or military dependent? For example, I can show them our state's YRBSS, but that does not identify if a respondent is a military child.
Yeah, that is a really great question. Thank you. Thank you for the question. So thinking off the top of my head, my recommendation would be to look at the American Community Survey. I actually just got asked to do that a couple of weeks ago, and I was so excited because we utilized that in the PACE D2A grant. But that does ask questions about active military duty, and the American Community Survey provides some really wonderful social determinants of health related data. We use it a lot for the PACE D2A website. So yeah, that would probably be my first recommendation. Other than that, off the top of my head, I can't think of anything, but if you message me your email, I will chat with some of my colleagues who help us out with the PACE D2A program and see if they have any additional suggestions, and then I can email you with their responses.
Some of the few things that we've kind of looked into as well with the Comprehensive Suicide Prevention Grant is utilizing those partnerships to reach those people who in those certain areas. So for example, if we're looking at military families. So we use people in the Georgia Department of Veteran Services. So if they're there looking for services or need help, we want to use those communication strategies to make that connection to see what's available, and also then see if we can build that connection and see if we get the information there. But that's one of the challenges that we've kind of noticed with the CSP grant is being able to get the access to that, because there is a barrier from the data that's protected, especially in the military itself. And so trying to find workarounds and ways to get the information without being intrusive and still being good partners and have everything, all the answers that we need answered.
Yeah.
We'll definitely, let's talk to you more about that as well.
Yeah, another thought might be, and you've probably already thought of this, so I apologize if you have, but you might want to check to see what the local veteran support services, not the government issued ones, but NGOs or small local organizations, what they're doing, because they might be able to provide you with data or contextual information that can be helpful for you. And then you can also, utilize their resources to help link military members or dependents with them as well. That could potentially be another idea, but you probably already thought of that.
Also, like different lodges with like the VFW, Veterans of Foreign Wars, or different organizations that have regular military presence, to be able to have access to those and build that community and those connections is also a way that we're looking at to get the information that we don't have readily access to.
Okay, are there other questions? Shirley, I think I saw you unmute. You have a question?
No, ma'am, I'm sorry. I accidentally unmuted. Hello, everyone.
I put you on the spot, Shirley. Sorry about that.
No problem.
Is there anyone else that has a question for Grace and DeAndre about the work they do? Preventing ACEs from a state government lens?
Well, I think that just means that we answered every question there possibly could be. But if you do think of questions later on, or if you're someone who doesn't like to talk in a larger public space, our emails are in the chat, our emails are on the slides. Send us an email. One of my favorite things to do of all time as part of my job is reaching out with other folks and talking to them. So we'd be happy to answer other questions that you may have, or like I said, show you more about what our projects are doing.
Okay, I like to give folks just a second to make sure that we're not cutting people off if they're in mid typing a question. All of the links that we shared, that we'll make sure that you all have access to it. We'll share it with you in the recording of the session. Like I said, be sure to please take part in our survey, our post survey after this session closes. It helps us to learn more about the topics that you all are interested in, what information you need to be successful in your part of the world. So please make sure to take that post survey. And I want to give a big thank you to Grace and DeAndre for your time. We appreciate you so much. And I hope that you all have a good rest of your day. We'll
Thank you,
close out here.
everyone.
Thank you, everyone.
Have a great day.
Thank you. Bye-bye.